Now we're moving into what has historically been one of the most interesting and important parts of this meeting, which is an opportunity for all of you to ask questions of the clinicians here in the room who have joined us. So I'd like to invite up my friend and esteemed colleague, former board member of the Chordoma Foundation, Dr. Ed Less, who's going to moderate the experts panel.
Thank you, Josh. So, normally when I speak to, I'll keep it brief. Normally when I speak to groups about my experience, I say something along the lines of, my name is Ed and I'm a Chordoma survivor, which is sort of like, but not quite the same as saying my name is Ed and I'm an alcoholic. And I'm not yet an alcoholic. And I'm also not addicted to my chordoma, and I would, like many of you, very much like to be rid of it. And so this weekend has been just amazing. The research workshop has been unbelievable. We have so many people working to do just that. And we have a panel today. If the panel members could come on up, I think you know who you are. Dr. Gardner, Dr. Cote, Dr. Heery, Dr. Hornicek, and Dr. DeLaney. So the way this is going to work, we had questions presented to us in advance of the meeting, and we'll go through some of those first. And we're running a little bit behind schedule, but I will try to leave time toward the end for questions from the floor. Now on this panel, you this morning already have been introduced to Dr. Stacchiotti and to Dr. Heery and Dr. Cote. Sitting on my left here, Dr. Gardner from the University of Pittsburgh Medical Center. He's a neurosurgeon with special expertise in chordoma surgery, transnasal endoscopic removal of those tumors, one of the real centers of excellence in the United States. Dr. DeLaney, many of you know, a longtime radiation oncologist based at Massachusetts General, runs the Proton Beam Center, does a tremendous amount of chordoma research, as does his colleague, Dr. Hornicek, sitting on the far end. He's a orthopedic surgeon, oncological surgeon, so cancer surgeon, and also heavily involved in research in chordoma. Now, if I was to go on and on with and complete the listing of all of their credentials, we would still be sitting here at 4 o'clock this afternoon, so I'll leave it at that. So, the first questions, I'm going to jump around here a little bit just to make sure everyone has a chance to speak. The first question I have relates to lung metastasis, and I'll direct that, Dr. Stacchiotti, first to you, and then Dr. Cote, if you would weigh in afterward if you have any additional comment. So the question is, more patients are dealing with this today, with lung metastasis, but few doctors seem to have experience with it. What treatments are available for patients with lung metastasis? Dr. Stacchiotti.
Okay. So the treatment available is surgery. When you have lung metastasis, it is very important to understand which is the extent of the disease. And usually we, at least in Europe, but I would like to have also the opinion of my colleague here, try to apply this kind of decision. When the disease is located only to the lung and the lesions are growing slowly, are not too many, and can be resected, the resection of the lung metastasis is the treatment of choice. The problem with chordoma is that this situation is not the most common one. Usually you have a local-regional relapse together with lung metastasis. And not often, or very frequently, what is causing the symptoms and what is the most relevant aspect for the prognosis is not the presence of the lung metastasis, but of the local regional disease. So if this is the case, probably is quite useless to remove the lung metastasis, and more localized approaches and less invasive approaches like radiation located only to one lesion or two lesions can be used to treat those lesions that are maybe more symptomatic or located in a more difficult position. But what you need if the tumor is growing is a systemic treatment. And so this opens the question to what we use in case of metastatic disease in chordoma. And usually our first choice is imatinib or to consider a new drug within a clinical trial if the trial is available.
Thank you, Dr. Stacchiotti. Dr. Cote, have anything to add?
I would agree with that. We've got a very aggressive thoracic surgery group at Mass General, and we've typically tried to be pretty aggressive with these patients. We've unfortunately had a number of failures where we do the surgery. By the time the patient comes back for their next set of scans, there might be evidence that new spots have shown up. So for me, it's the amount of nodules. So if it's just one or two, that's a pretty easy decision. If it's 30 and they're not growing quickly, then we don't need to be as aggressive. We can actually take an observation-based approach. When they start growing rapidly, that's the time for systemic therapy. I totally agree.
When you look at lung disease, if somebody has, say, 6 or 7 nodules, and most of the time with chordoma, it's not, as Tom was mentioning, it's not usually one nodule. If there's stability in the number of nodules, then those are patients that are more amenable to surgical resection. So over a period of, say, a few months, if there's stability, if there's continuing increasing in numbers, then those are cases usually that are not amenable to surgery and would go towards a clinical trial.
Just wanted to follow up on what Fran had said. For some other tumors where patients have isolated metastatic disease to the lungs, such as sarcomas, will cure patients with removal of the lung nodules. For chordomas, I'm actually not aware of any data that removal of lung metastases results in cure. And the reason is when you carefully look at the CAT scans in patients, they have a pattern of disease which we refer to as miliary. Miliary, the word actually derives from millet seeds. I don't think farmers here. Millet seeds are very small. And if you look at the lungs, it has a pattern actually not too dissimilar to tuberculosis. They have multiple small nodules in the lungs. And so I think the lung local therapy is really if a lesion becomes symptomatic. And often these lesions progress very slowly over time, but the thrust of the treatment really will be ultimately systemic treatment.
I would just echo that. We deal almost exclusively at the NCI in patients with advanced disease, or we have up until about a year ago. And so almost every patient we were seeing had metastatic disease in the lungs. And we have found that those areas grow relatively slowly. And we have considered surgery in the cases, as Dr. Stacchiotti mentioned, really when there is some concern that that lesion is going to cause a significant event. So if something's close to a major vessel or an airway, or if it's growing in a disproportionate fashion to other sites of disease, then we would consider resection. And we have done that a few, about, I think, 4 times in the last year or so. But those are the exception, I think. For the most part, systemic therapy is our approach as well.
I would agree with that. I think lung metastasis happens in the setting of recurrence of the tumor somewhere else. It's that tumor somewhere else that's far more likely to cause a problem than the lung disease. In general, we observe lung disease. I don't treat it. I don't send it to a thoracic surgeon because they likely will remove it. But there's no, that's not the limiting thing for the person with the lung metastasis. It's wherever their local tumor is. Now, if there's something that's growing or threatening, then I agree, removal is the treatment. But in general, I would say the answer to that question is actually observation for lung metastases. And then you have to look at where the primary tumor is and then understand that this now means the tumor is out. The tumor is not just in that local area, and so then systemic treatment. But I think observation really is first.
Unfortunately, lung metastases can occur even when the primary tumor is controlled, particularly in the spine setting where the size of the tumor has an impact on the risk of metastatic disease. And when we had looked, tumors that were larger than 500 cc's have a, and it's similar to other, like osteosarcoma, have a higher rate of lung metastases.
Yeah,
Bill,
so
do
as
you-
we get better with local control, we see cases with distant disease and, you know, not only the lung and chordoma, but also liver as well as another site, and also other bony sites.
Bill, you have a question?
Could you guys just clarify or define what systemic treatment is? We haven't talked about it, that word this morning, so I think there might be confusion.
As general definition, systemic treatment means a drug that given by mouth or by intravenous way is able to reach every site of the body so that you can treat at the same time every site where the tumor is. Then the question is which systemic treatment are available for chordoma patients, and so this is a critical question because we know that there are no approved drugs for treatment of chordoma. That means that we do not have very, very active drug, but we have data supporting, in case of need, some off-label agent, among which the first most commonly used is imatinib. Then you can try imatinib in combination with other things, or you can use EGFR inhibitor. There are only case reports about the activity of EGFR inhibitor, but there is also a new study opening soon with a new agent, at least in Europe. And then you can have clinical trials open in different places who make possible to try new drugs that are promising for the tumor. What we also know is that chemotherapy, the classic cytotoxic chemotherapy, is today not considered a drug, a class of drug with activity in this kind of disease, aside for very rare cases which are having the differentiated aspect, both at the beginning or coming later, maybe after radiation treatment, in which it could be that chemotherapy has some effect. So for these cases, chemotherapy can be considered, but generally speaking, cytotoxic classic chemotherapy is today not considered an active drug, an active treatment for this tumor.
All right, so next question.
I was just going to make
Yeah,
one
go
other
ahead.
comment in terms of local options. In addition to surgery, one has options of what's called an RF ablation, where a probe is placed in a lesion, or stereotactic radiation. These are other modalities that are used for local lesions that are less invasive than resection, and can, for some patients, be options for local nodules that are causing a problem.
Just to clarify, when we talk about these things and we talk about target therapy versus chemotherapy, they're all probably what you would all consider chemotherapy. So systemic therapy is a drug which generally most people call chemotherapy, but these treatments that Dr. Stacchiotti is talking about is not a typical chemotherapy where it has a lot of the toxic effects, where all your hair falls out and all that kind of thing. It's more targeted for aspects of the tumor. Is that fair to say? But so it's a little bit of us splitting hairs, but it's important understanding, but it does mean taking a pill, taking a drug that I think most people would consider chemotherapy.
Okay, so Dr. DeLaney, next question again to you. It seems as if there are new terms springing up around radiation all the time. One of the questions that is presented relates to pencil beam and spot scanning. And so can you explain what these modes of radiation mean, and are they different from regular proton beam radiation?
So the traditional proton radiation therapy was what was referred to as passively scattered, and pencil beam scanning is the more recent development which has emerged in the last 4 to 5 years. And the pencil beam scanning takes advantage of the charge on the proton and uses magnets in the head of the machine to steer the protons through the tumor volume. So conceptually what happens is you choose an energy for the proton that will penetrate to a depth within the tumor, and the tumor is broken into a series of 5 millimeter layers, and you set the energy appropriate to one of the layers, and then you use the magnets to steer the protons through that one layer. Then you reduce the energy and you go to the next layer, and so you sequentially are then able to treat the entire tumor. This has a number of advantages. One, you can treat with less hardware. You don't have to use what were in the past for passively scattered. We had to individually shape apertures using computerized driven milling machines for every field that was treated. So it was considerably more expensive. It took longer, and it was also a lot of stuff that you placed in front of the patient and the proton, so there was some secondary scatter of neutrons off of that hardware. When you now use the pencil beam, you can shape the fields electronically. It also allows you to give more dose selectively to portions of the target volume. Portions of the tumor may be hypoxic, for example. Radiation works through oxygen, so you might want to give more radiation dose to areas that are hypoxic, for example. So in fact, you just stop the beam in one area of hypoxia for a certain period of time. And it also allows you to better contour the proton beam around the target. Conceptually, because there's less stuff in front of the beam, it also has less skin dose. So when we had looked at our prior protocol patients treated with passively scattered protons, we always had to be aware of what the skin dose was, and the skin dose with scan beam is actually pretty comparable to X-ray, so you get less soft tissue changes than you would otherwise. So all of the new proton facilities are using scan beam.
Do you think in general it gives you more precision and less damage to the surrounding tissue?
It allows you to shape the beam, contour the beam better around the target than you could in the past. On the other hand, it requires a more sophisticated degree of control of the beam, as well as from treatment planning, in terms of making sure that the plan is something called robust. You have to be just very confident of the setup, and it's more sensitive to motion, for example.
It can be better if done right. Is that fair to say?
It's like most things, they're better if done right.
Fair enough. Fair enough. But better than traditional,
Yeah.
if done properly. Yeah.
He brought up the tumor being hypoxic. Chordoma is one of those tumors that has in the middle frequently, or there's usually an area where it's a very low oxygen content, and that's what the basis is of some of like the C novae and some of these drugs that are activated in hypoxic settings, like from threshold and various C novae is another one of those things, the Clostridium. So and you can actually do imaging studies to look at the hypoxia of the tumor, and Tom and his group has done that. So it's interesting. A lot of the drugs can't necessarily get to those hypoxic areas, so that's why they need to know that for their radiation planning.
Hypoxia, by the way, for those of you who don't know, the term just means no oxygen. So these areas of the tumor that have no oxygen in the center, often in the center.
A general comment from my point of view is that the quality of the pencil is very important, but also the quality of the radiation therapist, because it is not enough to have the protons, the hadrons and the good pencils. You also need a very strong experience with the tumor. Otherwise, you can use the pencil not in a good way. So it's very important to go to center in which there is an experience in treating chordoma, and not only to pay attention to where there is the good particle or the good pencil.
That's a very good point. I would use the same scalpel as Dr. Gardner, Dr. Hornicek, but you might rather that they do the procedure than I do.
And you don't want me near a proton beam.
I actually heard a patient told me, or a patient family told me yesterday that they went to see a radiation oncologist who said, "I'm not good enough to do this." And when someone tells you that, you should say thank you. Really.
Absolutely.
And when they say, go see someone who is, they're just doing you a favor. So,
Doing the right thing.
yeah.
Well, you want somebody who understands the behavior of the tumor or the disease, so that really makes a difference in terms of how the radiation is set up and where they need to deliver it.
Now, Dr. Hornicek, you were one of the authors in a recent paper that mentioned environmental insult as one of the possibilities in the pathogenesis of chordoma, something that causes notochordal cells to become cancerous. The question is there really any proof or anecdotal evidence, at least, of this?
Well, in the laboratory, we haven't been able to drive notochordal cell tumors to become chordoma, but it's largely in part because of the association of the benign notochordal cell tumors. I'm not a pathologist, Dr. Flanagan is here, but I like to go to their meetings, but I don't mind. Frequently we'll find a benign notochordal cell tumor that are more frequent. In one study out of Japan, there's like 20% of the people you'll find these notochordal rests and things, but what drives them to become chordoma, we don't know for sure. But what you'll find is you'll find these tumors, benign notochordal cell tumors or notochordal cell rests, adjacent to chordoma, and the thought is that because of their proximity to the tumor, that then that they then are derived from that. Wouldn't you, Dr. Flanagan, is that a reasonable statement?
I concur.
Yeah.
My colleague.
Yeah.
I would say that that's a theory behind most cancer development. We recently looked at the DNA of 5 different patients and their tumors and found a sequence of gene mutations that could explain, again, theoretically, going from notochord to a less aggressive tumor and then more mutations that would make it more aggressive. So there's more evidence behind this to support that theory. And what we're trying to do is understand what are the mutations that make it change. So at this point, we sort of have a story that fits with that theory, but I think it makes a lot of sense. You know, something has to make those changes happen.
If you think back to that model I was showing you, that your cells are constantly being bombarded with noxious stimuli. It could be radiation from the sun for melanoma. It could be different toxins that you get exposed to just through the environment. It could be infections. All these things can impact any given cell anywhere in the body and lead to more mutations in addition to what is normally already occurring as part of the normal biology. So it's whether these happen de novo just because these cells aren't supposed to be there and they're fragile, or whether they are there and they get insulted in some way that they can't recover from, we don't know yet.
But benign notochordal cell tumors have a different radiographic appearance, and when you take them out or deal with them, they're much harder to deal with because the tissue is unlike a chordoma that's more gelatinous. So there's been attempts to get some of these cells to look at them in the lab, and it's certainly more difficult.
Do they grow in culture? Has anyone tried that?
Well, it's hard to get them to grow because they don't proliferate like that. So, but we have been able to sequence, get from fetopsies fetal notochords and then isolate the notochordal cells using laser microdissection, and then doing sequencing like Slim presented yesterday, where you can even do single cell drop-seq to try to get data that may help you decide, like Paul was saying, is the progression that would then go on to a chordoma.
So let's turn to pediatric cases for a minute, because we're seeing more and more cases in younger people, even in babies. The question is, how does the behavior of pediatric chordomas differ? And do newly diagnosed pediatric patients need to see a different set of specialists? Perhaps we'll start off with Dr. Stacchiotti, and Paul, perhaps you could weigh in thereafter.
I think there is a defined group that we're starting to understand. Children under the age of 5 are much more likely to have a dedifferentiated type of tumor, and just dedifferentiated just means it's ugly or it's got far more mutations. It looks less like a typical chordoma because, and it behaves much less like it. And those tumors tend to be much larger when they present as well. They look different on MRI, they have more cells in them, and they tend to regrow no matter what you do. And probably those children still need surgery to remove as much as possible, but they probably are the ones who most desperately need some type of chemotherapy. There are case reports of some of those children responding well, at least temporarily, to chemotherapy. That's very encouraging, but it seems that that's a very different group and probably does need different treatment. I think the way we manage pediatric chordoma is that we do all of the care with a pediatric neurosurgeon. So we enlarge our team by adding not just our skull-based team, but adding a pediatric neurosurgeon, because there are a lot of different considerations in children that are necessary. And I know there are a couple of other groups that treat it this way. And I think that's the appropriate way. You combine an expert who understands the disease with someone who understands, the child. But other than that group, they become more and more similar. There certainly are incidental tumors found in older children, but I think that specific group of the dedifferentiated, which tend to be the very young children, is well known to have a much different behavior and much more difficulty to control. But perhaps then in the future we'll have even better results, as we've seen with some other kind of tumors, where once you figure out what that chemotherapy treatment is, surgery no longer becomes a primary treatment, which is, in the end, a good thing for them.
There are 4 types of chordoma. You have a conventional chordoma, which is the most common. A chondroid chordoma, which has a cartilage component, is found more often in children. So are the poorly differentiated, which are different than the dedifferentiated. And the poorly differentiated are those that do respond and you find more in children as well, and will respond to neoadjuvant chemotherapy.
So there's a really interesting biology with the poorly differentiated versus dedifferentiated versus conventional. So you've heard about T brachyuria that you've heard a number of times. So T is still expressed in poorly, but not in dedifferentiated. So there's some biology there where it's lost expression and looks more like a sarcoma under the microscope. The poorly differentiated type also has loss of this gene called INI1 almost universally, and that's it's a little bit too complicated science, but it's part of the epigenome, and we have some targets for that I think will be interesting. But I don't know what's happening in Europe, but I think we're going to start moving towards chemotherapy and radiation only for these types. That's my guess, just based on my own experience with these patients and some of my colleagues. But we'll see. It's still early days.
I agree with my colleague. I think that this is the exactly niche in which should make an effort to collect all the cases and to know better the disease from the clinical point of view, because overall we are quite ignorant about this setting. I don't know if Dr. Flanagan has any additional insight on the brachyury or biological aspect of the differentiated type that is usually involving very, very, very little children, so before 5 years old. And I think that you can, in general, say that more often are located to the skull base, and this by definition implies that the kind of specialties involved are different from the one you involve for the sacral chordoma. And I don't know if the general principle for radiation and surgery can be considered the same than we are applying for adult chordoma. And to which extent has to be considered the risk of a secondary tumor related to radiation therapy, and if we have any data with this respect, because in a very small children we need to cure the disease, so for sure we need something effective, but also to consider which are the late side effects. So I don't know if Adrian.
So go ahead.
I don't think there's a great deal of done. What you've said about the loss of INI1 is true in some of the cases, but not all of the cases. But it can be looked for, and clearly it would be great to get them into clinical trials. But it's only about, I think, it's certainly not all of them. So there are different groups, and I think of that group, I think we've sequenced 2 of children high grades. I think there it would be great to be able to get some of those samples and sequence them in depth, whole genomes, and try and look at them to look at the differences. And de-differentiated. I don't think we've sequenced any de-differentiated. And to look at the the conventional component and directly compare with the de-differentiated component would certainly give us some insight. But as we know, they're rare, so I don't think we can be too fussy. We should just get as many samples as we can and just try and analyze them.
So Dr. Gardner, we know that these are slow-growing tumors. Often takes a long time to diagnose them, and they're often in difficult places. Is there any evidence that operating on these tumors and removing them, doing a subtotal resection, is there any evidence that you make the remaining tumor more aggressive? Does it grow faster after you've been in there?
I think in the skull base, I don't know of any evidence that going in and operating on the tumor activates it in some way. Certainly you could come up with theories that the tumor doesn't like, the exposure to oxygen perhaps, but I have not seen an example of this. I think, the question is the tumor discovered at a time when it's becoming more aggressive, and then perhaps someone operates on it and it continues in this aggressive pattern? Again, I have not seen cases. I'd be interested to see if there are sacral cases that you guys have seen, but I've not seen that in the skull base, where a tumor has clearly changed its behavior because of a surgery, even a surgery that was, subtotal or an incomplete removal. And I can't think of a good theory behind why touching the tumor would do that.
Anecdotally, I've seen some patients, usually in a setting where someone is not aware it's a chordoma, and they'll go in and they'll do an intralesional incomplete resection. And from my perspective, the growth kinetics seem to change, because occasionally patients will have chordomas that are not diagnosed initially. For example, they'll have a classic case, they'll have a lumbar spine MRI for back pain, and they won't get axial images through the sacrum. And in retrospect, you'll see a small chordoma, which was there but not noted because they didn't do what we call axial images, transverse images. And a few years later, the patient will have increased symptoms, and you'll be able to see this tumor change very slowly over time. In terms of a rationale for why the kinetics might change, you have a surgical wound with a lot of growth factors for repair of the wound, and I think Fran Hornicek's lab has done some work on just the crosstalk between the matrix and the tumor, and I think it probably changes the growth kinetics in that setting. We have a lot of tumor cells and a lot of growth factors.
I'm not a radiation oncologist, but I'll talk about it. Dr. Soot always told me, Herman Soot, that if you have fewer cells, radiation works best. So I think whether you're at the skull base or whether you're in the sacrum, if you can get it down to fewer cells left behind, whether because at the skull base you can't always do an en bloc or resection with negative margins, but if you can decrease the number of cells so there's a gross total or fewer cells left behind, whether it's in the sacrum or whether it's in the skull base, I think that's when radiation probably works best.
I just wanted to give a thought on this, because I think this question probably comes from patients who have they've had a surgery and then their tumor grew back really quickly. And when we think about anecdotal cases like that, we have to really try to frame them as an unknown. And this is one of the worst things about the internet, not just in chordoma, but everything. You only hear about the outliers that don't make sense necessarily. And I think it's important then, if we're going to frame things with anecdotes, to look at the other side, which is, what about patients who didn't have surgery or radiation? Are there ever cases where those tumors grow much faster than you expected? And Dr. DeLaney showed us one 2 days ago, that a patient opted not to have any therapy and no surgery and no radiation, and his tumor grew very quickly. So I think it's important to just realize that these are good theoretical questions, but in reality, it is going to be very difficult to prove it one way or the other. The only way to do that would be to observe a patient that comes in and not do anything, and see how quickly their tumor grows and then do surgery and see how quickly, and nobody wants to do that. So, and rightfully so. So it's an interesting question. It's a good theoretical question that we could talk about, I think, for a long time, but I don't know how the answer would be achieved.
So there's a group called which I mentioned to Silvia in a couple emails, a Sacral Pelvic Study Group that has come up with a quality of life questionnaire specific for sacral chordomas. And then we've also started a study, a multi-institutional study, collecting cases where they've been missed for a period of time to try to get the growth parameters of some of the chordomas that have been missed, but we have prior films. So the only way we're able to do that is through a multi-institutional study, which we're doing now. And that's going to be run, Pete Rose and his group from the Mayo Clinic are going to be heading that, I think.
I think one of the problems also with these anecdotes is, everyone here is quite aware at this point that chordoma has this really wide range of behavior. You can have these children less than the age of 5 who, no matter what you do, nothing controls the tumor. And then you have some people who actually follow a very small chordoma, and then when it starts to grow, finally remove it and never have another problem with it again. So there's this huge range, and most fall somewhere in the middle of it. But I think what it does point out, and one of the very important things that this foundation has done is getting to experts, so you don't, if you do have surgery, you don't have a incomplete surgery. If you're going to do it, you have the maximal possible surgery you can have while still preserving best quality of life, and that's a very fine line to get that treatment right. And I think the Chordoma Foundation has done a great job of identifying experts to treat this, really all over the country and help patients find the right people. And that probably is the best thing to avoid, and hopefully not have to answer that question.
Related to the regrowth of residual tissue, perhaps Dr. Heery, there's a number of patients, as you know, who have damage to their pituitary gland, for example, related either to extraction of the tumor or to follow-up radiation, who then go on to require hormonal therapy. So they require thyroid hormone, growth hormone, etc. And so there's some concern that the administration of those hormones in the aftermath of having a tumor resected will in fact encourage regrowth of tumor.
Right. It's a good question, and this was the only one on the list that I just had no idea how to answer. So I'll tell you some thoughts that aren't directly answers to this. One is that we do know that hormones can affect both the growth of certain tumors as well as the immune response to tumors. And those tend to be very specific tumor types. They usually are associated with glands. For instance, in the breast, those tumors are more likely to respond to estrogen and can be driven by estrogen. And similarly, because the prostate is an androgen-driven organ, it tends to respond to androgens. And so we know that if we block those pathways, that those tumors are likely to respond or be controlled. Maybe, Dr. Flanagan, we can bring her up to the microphone again. I don't know of any hormone receptor overexpression on chordoma cells, and I don't know of any data that indicates that any hormone drives chordoma growth. In fact, as we've seen in the last couple days, there doesn't seem to be that those pathways are upregulated one way or the other. So if there is any other thought there, I'd be interested in hearing it, but I can't think of a mechanism why that would be true in chordoma.
No, I agree with that. To my knowledge, there's no evidence that they're hormone-dependent tumors.
Awesome.
Yeah, we recently submitted a paper looking at some like CDK11 and its relationship to androgen receptor. And when you do the sequencing and things, you can actually, it points to that. And then there's some of the tumors are now being targeted with the androgen receptor. So it's not a crazy idea to look into.
I think you have to be, it has to be weighed. Every single one of these things is risk-benefit. Loss of hormone function, which a lot of times in the skull base is inevitable after appropriate doses of radiation, has an impact on quality of life and if not done properly, quantity of life. So people who don't have their loss of hormone properly treated do not live as long.
Yeah.
And so you really have to take that into account. Not only will you not feel good, you actually will have many more health problems if you don't have proper replacement. Now, things like testosterone and growth hormone get a little trickier because their impact perhaps is a little less, and there's some theoretical reasons why they could impact the growth of a bony tumor. But the fact of the matter is that these things are being done to replace what your body normally makes. And so I think it's important to keep that in mind. And in general, without any evidence to suggest it's bad for you, there's a lot of evidence to suggest it's very good for you to have those normal hormone levels.
Yeah, thanks for bringing it back to the most practical point, which is you can't live without most of those hormones. So
Testosterone.
really don't have it. I have to tell all of our prostate cancer patients that they.
So with respect to biopsies, there's still a lot of confusion. Even this weekend, when I sat through the ICRW through the research workshop, they're still talking about biopsies, and we've heard in various venues that you should never do a biopsy. There's select indications for biopsy. So when should a biopsy of a new diagnosis occur, and when should it not occur?
Can we separate it? And I would think it's important to separate between spine and skull base. And so I think this is most relevant in the skull base, in the spine rather. So I think.
Yeah, I would agree, because a lot of and I think Paul would agree, that some of the skull-based lesions that are radiographic classic for chordoma, you'll probably treat like that because of the morbidity associated with it. But for the mobile spine and sacral lesions, I think that it's important to do a biopsy that doesn't cause a problem with the subsequent procedure. So that means, and usually with a needle, it's possible to obtain enough cells to make that diagnosis. Even sometimes a fine needle will give you enough cells to make the diagnosis of chordoma. What's a little unusual is chordomas will actually seed the biopsy tract. So there have been a lot of studies with musculoskeletal tumors where the biopsy does not necessarily seed the biopsy tract, but in chordoma it will, and you can get chordomas growing in the subcutaneous tissues. So you want to
follow what he means by biopsy tract.
Yeah. So from where the biopsy entered the skin until where it reaches the tumor. So you probably want to remove that in the sacrum or in or at least plan where your incision's going to be, so you can then remove that when you remove the tumor. The other option is, and some people feel, well, if that area is receiving radiation, or then you may not be as worried about seeding that biopsy tract. But you want to plan where the biopsy's done. And we do fewer and fewer open biopsies for all the musculoskeletal tumors that we deal with, I would say.
There's a question over there related to.
Just a comment.
Yeah.
I agree with what was said in terms of the deep biopsy, and this really relates to spine, mobile spine as well as the sacrum. I feel very strongly that you should almost always do biopsy in those circumstances. And the current techniques in terms of designing the site of the biopsy and some of the precautions that you can take during the biopsy, using a dual needle technique, for example, to protect the tract and so suggested here, planning the biopsy track in the surgical field so you can potentially excise it during the surgical intervention. And then the third is that sometimes what we do in the spine when we do a transpedicular biopsy, we do place a small amount of cement on the way out to prevent the tumor seepage from the biopsy site. So you can take all these precautions, but I do feel very strongly that in the mobile spine as well as in the sacrum, you should always do a biopsy before we subject the patient to a major surgical procedure.
Yeah, for all of you who don't know, that's Dr. Gakoslan. Zia is one of the pioneers in terms of doing some of these larger spine and sacral resections. He was at Hopkins and now he's at Brown. He's one of our colleagues, and I agree with everything he said. I think very good points. So if you have any questions about any of those things.
And that sounds pretty complicated to me. The point of that is, if a biopsy is done at a center that knows what they're going to do for that tumor and the right way to do the biopsy, they will do all of those things he talked about. Dual needle, leaving cement, marking the track, etc. It's not that you have to know what all those things are, it's that you have to go to a center that will know how they're going to treat that, how they're going to biopsy it appropriately. And again, it goes back to experienced centers, which I really think is the importance of setting up these centers of excellence that's being done. In the skull base, it is a little different, and part of that is because we have a technique of going through the nose where we can land basically directly on the tumor. The risk of seeding is there. It seems to be a little bit lower in the skull base. It's probably around 1% to 2% with radical removal if patients will get seeding. We've had 2 cases out of 150 or more through the nose where there was seeding in the nose. We had to go back a couple of years later. But we haven't had that after biopsy, and generally at the time of surgery, we're able to see almost all of the tumor, which is a little different. For me to go through the nose and open the sinuses to see the whole tumor is different than opening what has to be done in the sacrum to see the whole tumor. So there's a little bit of a difference there in the skull base. The other difference is that it's very difficult or rare for us to be able to get around the whole tumor and remove the tumor and normal tissue in one chunk, which they can do a lot of times in the sacrum. So that's why there are differences there, and also why it's sometimes in the skull base you can do a biopsy in the same setting as you do a removal. So you can take a piece of it, know that it's chordoma at that time, and then go ahead with your removal through the same way you would do the biopsy. So that's why there's a difference in the two.
In the past year, I've had at least 2 cases of people coming. They thought they had a chordoma, and they were scheduled for major surgery, and they had a giant cell tumor, say of the sacrum, which is a benign tumor, and you treat it considerably different than you would a chordoma. So in the sacrum and also in the mobile spine, when you can get a diagnosis, I think it's important, and you have to do it in the right way. So there's a saying that where the biopsy is done is the same place that the definitive surgery should be done.
I just wanted to point out one thing that was kind of interesting that, as it was brought up, is that what you're hearing is that certain imaging techniques are necessary for all of this planning. The surgeons really need very specific imaging techniques. And I've had patients say, well, they did an MRI last week, and you did one 2 weeks, why is it a different MRI? And the point is, it is. I guess that comes up quite a bit, is that a surgeon might need a very specific sequence of images and timing of contrast, and at some point it becomes almost impossible to try to explain some of those differences. But I think it's important for everyone to hear that these techniques that you're talking about are things that have been refined over years and require a lot of information to make the decisions. So just bear that in mind.
Yeah, I don't think there have been any talks here on molecular imaging and things. Was that right, Josh? But there are techniques being developed now to look at where at MIT now you're able to look at single cells that are left behind in a tumor bed. Some of the problems become blood interfering and things like that. But with molecular imaging, we're getting a much much better, hopefully, at imaging at least tumors in mice and things, and hopefully, and there's some clinical trials now trying to be applied to some of these tumors. So it's something to think about for the future.
One of the questions that arises is, let's say I'm a patient who is 9 or 10 years out, and I've had surgery and radiation, and the years have gone by, and perhaps a bit of residual tissue sits there, doesn't do anything. At what point can I stop getting scanned, or do I need to support the radiology industry forever? Right, yeah, I think I know the answer to the question.
In terms of imaging, our protocol after 4 to 5 years has been annual MRI imaging of the primary site. We've continued to get chest x-rays after they are less sensitive than chest CTs, but they have about 1/10 the radiation dose. I think chordomas can recur late, and we've seen recurrences out beyond 10 years, so we've continued annual imaging. I think, at least in our patient practice, as long as we continue to see the patient.
So I'll buy an MRI machine for my living room.
Yeah. No. I was at Hopkins giving a grand rounds there, and one of the comments, Dr. Koslin was there. If you remember at the end, somebody said, well, if you wait long enough, Dr. Sim or somebody from the Mayo Clinic, there was a comment that if you wait long enough, they'll eventually all recur, which isn't necessarily true, I think. But the idea is that we do see significantly, there are cases that are 14, 15, 16 years out where you'll see a local recurrence. And that's why I went to the combination of using radiation plus surgery for some of the cases, because I haven't been seeing those recurrences greater than 10 years out, where in surgery alone I have. So,
yeah.
One very exciting presentation yesterday was on what's referred to as circulating tumor DNA. This is kind of interesting technology, actually. It probably arose initially out of fetal monitoring. In pregnant women, you can detect the baby's DNA, and you can do genetic testing without doing a biopsy, in utero biopsy. But for tumors now, tumors will shed their abnormal DNA. You've heard it's a genetic disease with changes in the DNA. And there's evidence from a group at Johns Hopkins has looked at circulating tumor DNA. They have detected it in chordoma patients. And the hope is, as you correlate the circulating tumor DNA, which is it's a fraction of the circulating tumor, a fraction of the DNA that's circulating you detect. For most patients, it was in about the 1% range, even in patients who had metastatic disease. But the thought is, over time, that if that proves to be an accurate predictor or a test for recurrent tumor, then you might be able to stop imaging the patient and only image someone if you detect circulating tumor DNA. Very exciting.
Is that the so-called liquid biopsy term that gets thrown around?
That's exactly right.
Yeah.
It's a liquid biopsy.
Mm-hmm. Awesome. So we have a few minutes for questions from the floor. If anyone wants to pick a mic, and a mic will come to you, Joel. Go ahead.
Yes. Over the years, my attitude about chordoma has changed. Do we consider chordoma a benign tumor or a malignant tumor? And is there any point in time, like they do with respect to prostate cancer, do you consider a time where you would not treat the chordoma?
It's a malignant tumor in the sense that, at least for the sacral lesions, and mobile spine, there's about a 20% risk of metastatic disease. And as with other solid tumors, larger tumors have a higher risk. Patients who have a local recurrence have a higher risk. And then in terms of patients who wouldn't necessarily need to be treated, there's certainly some experience with skull base, and occasionally we'll find incidental lesions in patients, sometimes we're not sure if someone has a chordoma or a benign notochordal tumor where there's a lesion within the cortex of the bone. We'll observe those patients. Now, patients who have extraosseous disease or outside the bone, if someone is elderly and has other medical problems and we aren't sure what the pace of the disease is, we'll sometimes follow patients with sequential imaging without treatment.
I have 3 patients that I can think of off the top of my head right now who have metastatic disease where it's traveled to their lungs, but it's growing so slowly that we're just watching it right now, and we're kind of waiting for the right clinical trial to pick. So I'm completely fine with observation in the right clinical context.
I'd just like to point out that the comparison to prostate cancer is a really interesting one because they are really opposite ends of the diagnostic spectrum. Chordomas almost always are found because of symptoms, and prostate cancer, over 80% of the time, is not because of symptoms. And so when you think about that, there is discussion in the field of prostate cancer, and I can say this as someone who works in prostate cancer a bit, that PSA screening is actually hurting more patients than it's helping. Okay, so along the lines of what you're asking, are we overtreating? And we know that we're overtreating at least a third of patients with prostate cancer, in that they're having radical prostatectomies, and then, which is a major surgery to remove the prostate, but then as a result having bladder dysfunction and sexual dysfunction. So I think if we had that problem in chordoma, where we were diagnosing it so early that we could wait around and see if it was going to grow, that'd be a good problem to have. But I think chordoma is a really different animal than prostate cancer, especially in that we actually know the prognostic indicators in prostate cancer fairly well, of which patients are likely to do very well and which patients aren't. And in chordoma, I don't think that's quite as clear either. So
I think that goes back to the spectrum of disease. There very well may be this very small percentage of chordoma that's sort of an inactive, benign precursor to the more malignant versions of chordoma, but in general, most chordoma is malignant when it presents. I think that's part of our understanding. As you say, it's taken decades to understand that about prostate cancer, and that's a disease that is extremely common. This is a very rare disease, and I think a lot of the work that's going on will help us understand it genetically and maybe someday identify that small percentage. But as a general rule, it's a malignancy, and if anything, unfortunately, sometimes it ends up undertreated.
Yeah, but I'd like to re-emphasize what Tom said. I think there are some cases, and even in some younger people, where there are tumors that are completely within the bone. There's no soft tissue mass, and they look like even have some features consistent even with a benign notochordal cell tumor, but there are some areas, and they're biopsied and they're a chordoma. There are cases that we followed, those patients that are asymptomatic, and they've had very little change. So I would agree there's a spectrum, but I agree there's probably there's quite a spectrum of disease. But I think you get an idea too by, if you have interval follow-up, as to what the progression or lack thereof may be, and help determining how you should manage them. But it's a good question.
Then, just to complete, probably the percentage of cases with distant metastasis in chordoma is a bit underestimated, because especially in the past it was not very common to ask for a CT scan of the whole body. And so this is also a reason why in the literature, till a few years ago, you could find, and many doctors were used to say to the patient, this is a benign tumor. But this is not a benign tumor and has to be treated at the first presentation to try to cure the disease, because in case you cannot achieve this kind of cure, becomes very much more difficult to approach the tumor later. So it has to be treated really as a malignant tumor, even if the local relapse is more common than the distant metastatic disease.
Okay, first Joel, and then over here.
Thank you. Perhaps Dr. DeLaney, you can explain to me something I've never understood. My understanding of the data is that, in fact, after the first 5 years, the likelihood of recurrence of chordoma actually goes up from 20% to 40%. But I know that at the same time, the follow-up MRI scans tend to go from 6 months to a year. And there's a view that you don't need to be tested as frequently. I've never quite understood why that is, and perhaps you could explain to me and to the group if in fact that's true and why that's the case.
At least when we've looked at our data, fortunately for primary spine tumors, we're actually seeing relatively few local recurrences. In the skull base, the risk of recurrence was maybe approximately about 30% in the first 5 years, and then maybe another 20% over the next between 5 and 10 years. So there was about 30% of patients had recurred within the first 5 years, and by 10 years, about 50%. So there was a slightly lower risk between 5 and 10 years. Right, so there's a slightly lower risk. In terms of I think most of the follow-up protocols have been developed empirically. We haven't randomized people to different follow-up protocols. When you do follow-up imaging, it also gets down to what the treatment options are. And you could make a case, at least for some of the currently available salvage therapies aren't terribly effective at the moment. And so how aggressively you image, you might detect something that you won't necessarily need to do anything about or can do anything about. But at least the protocol we've adopted has been MRI imaging every 6 months for the first 4 to 5 years, and then annually. Then in terms of chest surveillance, chest X-ray alternating with a chest CT. Now part of that is based, at least in our experience, where we're seeing relatively few local recurrences. We're positing that the metastatic cells would have metastasized before any local treatment was done. So we thought that 5 years is a reasonable estimate at which to switch over to chest X-rays, because our sense is the majority of people who would have metastasized by 5 years.
Anyway, I think we need to disclose that among the experts, there is not an agreement on which is the best follow-up timeline and approach. And this is one of the paragraphs in the new position paper that is rewritten by all those who are reviewing the paper, because there is not an agreement, because nobody was able to prove that to anticipate the evidence of the relapse can improve the prognosis. This is the reason why. So I think that as a clinician and a researcher, we need to know if what we are doing help the patient, and so it is normal to include the follow-up, because if I use surgery or radiation or the combination and then I do not ask for a follow-up, I can say that all the patients are cured because I cannot detect the relapse. So there is a mixture of need that is on one side the clinical need of the patient to be treated in time, and on the other side also the need of all of us as a community of physicians and patients working together to know which is the effect of our treatment. So if I perform radiation and the next CT is after 5 years, I can say that none of the patient is relapsing before the 5 years. So you see, there are many aspects, but there is not an agreement among the physician on which is the best follow-up, nor for the local phase, nor for the metastatic phase of the tumor.
So a great discussion, but we have a few others lined up, and we have just a little bit of time left, so let's get to some of the other.
Can I just make just one? There are, in the United States, there's a group called the NCCN, and the NCCN came together and as a subgroup of the bone sarcoma group came up with some, they're only guidelines, but they came up with some guidelines for chordoma management. So it's something to look at.
All right.
You discussed protein beam radiation. What is the difference between that and gamma knife radiation?
So gamma knife would fall into the category of what's referred to as photon or X-ray. And a gamma knife has a large number of cobalt sources with some, what we call collimators, that focus the X-rays onto the target. And at least biologically and physically, it's similar to other focused X-ray techniques, which include intensity modulated radiation therapy, stereotactic radiosurgery, stereotactic radiotherapy. Biologically, X-rays and protons have relatively similar effects on cells. Protons have about a 10% higher biologic effect, but we compensate for that by prescribing a 10% lower physical dose. The real difference between X-rays and protons is the fact that X-rays, once they enter the body, they exit out the other side. And beyond the target, they continue to deposit energy and can have effects on the cells outside or beyond the target. So conceptually, X-rays or protons give 50 to 60% less total body radiation dose. That additional radiation dose from X-rays has no benefit for the patient. To be honest, realistically, we don't know how much of a downside there is to that additional X-rays. When we looked retrospectively at patients who had proton treatment versus X-ray treatment, and we did a matched analysis with what's called a SEER database, a national database, the risk of radiation-associated second malignancies was about half as much with protons. But it turns out that radiation-associated second malignancies are a rare event. If you treat 1,000 patients, the risk of a radiation-associated second malignancies in patients who survive 15 years is about 0.5%. And so it's a relatively modest event, or a modest number of occurrences. The biggest risk is going to be for younger patients who are at risk for many years. Also, the larger advantage for protons is going to be in patients who have large tumors. You're going to spare a larger volume of tissue beyond the target. Also, in children, of course. And then if in the brain, for example, the skull base, the tissues you're sparing are going to be, part of it is going to be the brain. So you'll have a lower radiation dose to the brain, which, at least for most people, is a good thing.
One quick point about gamma knife is that gamma knife is really good at treating really small areas. And with chordoma in general, radiation is used to clean up all of the edge of the tumor, the entire area of the tumor. The problem with gamma knife, at least for upfront treatment of chordoma, and I think part of the consensus statements were that radiosurgery like gamma knife is not part of the primary treatment, is that it doesn't treat the whole area where the chordoma was. And unfortunately, anyone who's had a chordoma recur know it usually happens on the edge of the tumor. And so if you just treat the little center of the tumor, you're not doing the proper treatment for that. And that's the problem with gamma knife, at least as a primary treatment for it, whereas protons treat the entire bed of the tumor.
Thank you. Next question, please.
Hi, my name is Chris, and I first of all want to thank you all for being here. My husband, Marty, suffered from lumbar chordoma beginning at L4. Over a period of 5.5 years, he had 3 major surgeries, passed away in 2013. My question is on behalf of my sons, 2 grown sons in their 40s, one of whom works in a job that does a lot of damage to his back. And he says, "Mom, is it happening to me?" I'm wondering about statistics or anything you can tell us about heredity in this. My husband's 2 sisters who are retired also wonder about that. Thank you.
Dr. Flanagan, do you want to handle that?
You're the one.
No, I mean, she can make, the familial chordomas, there's what, 6 families or whatever. There's a certain number, it's very rare, and in those cases, there's a duplication of T brachyuria that's been identified, but it's most of them are sporadic. So only if there's a family that of of members with chordoma would you have to worry about that? So, yeah, multiple family members, and that's extremely rare, so it's a finite number. And then in those cases, it's thought to be a genetically, it's related to T brachyury. But Adrian, do you want to make any more comments on that?
In general, the answer to that is no.
Yeah,
You don't have to worry.
That's correct.
As with everything in in medicine and nature, there are always exceptions. But
don't worry about it.
Yeah.
We're talking the incidence of chordoma is 1 per million per year, and what you're talking about probably it can be fairly estimated at 1 per billion per year. So you'd have to be really special. Todd.
Yeah, this is actually more of a food for thought than a question. You had brought up the test of the bloodstream and the tumor shedding cells, and there was a new test that actually tested for that. Well, we were fortunate enough to learn about that test, and Brittany and I actually took that test not more than 4 weeks ago, and 2 weeks ago did get the test back, and it was inconclusive. There were no abnormalities found. I know that every chordoma is different, so that's just mine, but I wanted to at least share, so all of you knew that there was a chordoma patient that just recently took that test, and unfortunately it did not help, but we hope that the technology will continue to evolve. And if anybody wants to see those results, let me know.
Awesome, thanks, Todd.
So one issue with that is that the current technology for liquid biopsies is only looking at a very narrow subset of genes. So you can think of it like the guy who loses his keys but only looks under where the street light is. And so we're only looking at a couple of hotspots for those tests. I don't know which company you sent it through, but I looked at the panel for one of them, and they're not really relevant genes for chordoma, at least not most of them. So as our technology gets better and as that technique gets better, we'll probably find more information. I think for surveillance, to see if we can detect disease, it's going to be looking for chordoma-specific genes like T and things like that.
But I do want to say thank you, and for everyone here, thank you for taking part. We're learning. We don't know quite what to make of these studies yet, but that's what's happened over the last 5 years through the Chordoma Foundation. Is what we know is 1 million times more than we knew 5 years ago, and it's because of willingness to participate in these studies that may give you no answer and may not help you, but it does help the science, and it helps all of us learn, and that helps chordoma treatment be better. So it's very important.
Yeah, that's why I mentioned it.
I do just want to add that this test did include EGFR inhibitors and also VEGF expression and also VEGF, and none of those were detected as abnormalities in the blood test. Sure. There were a couple of targets that were present but were missed.
Yeah, I want to make this
Can I come in? So we've done this. The approach that we're taking, we've done it on over nearly 200 patients now in sarcoma. Because you don't have recurrent mutations, the approach you take is that you do low coverage whole genome sequencing. Yeah. And you detect recurrent alterations and breakpoints. And therefore, we looked for 3 to 5 targets in the plasma. And they are very specific for that particular patient and that specific tumor. Yeah. So if you find a result, it is very informative. You do find results. The problem is if it's very small and if it's not apoptotic, you can have a 2-centimeter tumor and we pick it up, the rearrangements at very high numbers, and you can have a big tumor without much apoptosis and you don't pick it up. So it's very tumor specific depending on the behavior. So if you're positive, it's very informative. If it's negative, it just may be uninformative. Yeah.
Yeah. I just want to cement that point because it's a really important one. That EGFR mutations, for instance, maybe the one. Right. Right. EGFR mutations, though, in lung cancer, for instance, it's a great target. But not all EGFR mutations are created the same. So just because someone had but 8 years ago, they would have all been treated the same, and now they're not. And similarly, there's a mutation in melanoma that we can give a drug for, and it works. But in colon cancer, that same mutation exists, and the drugs don't work at all.
Okay, so we're over time. We have 3 people standing who have a question. Those are the last 3 questions. We'll start with you.
Hello, my name is Adrian. Thank you all for being here today. I'm seeking clarification. We heard a lot about brachyury and T-box, and then we were presented with a couple of slides about patients who were not chordoma patients participating in a trial. So my question, I'm not quite sure how to formulate it, has to do with what are the opportunities for research with other patients with different cancers? And has this already begun? Do you pair yourselves with other researchers? And what does that mean for us as chordoma patients?
Yeah, I'll tell you that really quickly. It's a good question. So we do believe that brachyury is expressed in other tumors, but in very small nests of those tumors. And we believe that brachyury drives those tumors to change from how they originally developed as epithelial tumors, similar to the cells that they came from, into cells that act and behave very differently. And those are cells that we know are capable of metastasizing, setting up shop, and starting a new tumor somewhere else. So we actually became interested in brachyury for nothing related to chordoma. And without Josh, we never would have known to put patients with chordoma onto that study. So that study was originally intended to focus on patients where we had observed brachyury expression in small nests of tumor cells. So we are developing those vaccines in other tumors actively. We have planned studies. Some of them are going to be multi-center studies, that will be run by the companies that we work with. So yes, it is going forward. And I think your point is a really good one. Does it benefit chordoma to see that this could work in others? Absolutely. And can we also learn something about the biology in the cells that express brachyury that are not chordoma? And we think so, and that is an area of research in our lab.
Okay, the penultimate question.
I want to express my gratitude to all of you and all the researchers and biologists, and just extremely grateful to the foundation and Josh. And I also wanted to touch the subject of metastasis through surgical seeding, which also leads to the point of biopsy, which, like Dr. Gardner and Dr. Heery said, it's hard to prove anything, because it's so rare and the history is very limited in such a rare disease. However, if you look at the history of the medical data, complete resection and radiation is the most viable way for long-term survival. And until something wonderful, which is in the seeding of it, and thankfully again, I think that I was going to ask you how, if you guys ever addressed or have heard of recent, even some doctors are trying to do pre-surgical radiation to avoid seeding, and also any other experiences that you've had with surgical seeding, because a lot of people who have had lung nodules or other nodules, we don't know, it could be surgical seeding. And chordoma, since we hoped it's impossible on the spine to get it en bloc, almost impossible except if it's for the sacrum, which is small size and you can get more clear margins around it. I was wondering how we can address this and take this in consideration, because through the viewpoint of the doctor, I understand the necessity of the biopsy, but also I, from my experience, have seen from my studies and contacts with other people where they have partial surgery and then the tumor mutates and becomes more aggressive. And also, there's a reason why some doctors really are not for the biopsy, if it's possible to detect it through an imaging.
We get a couple of comments from our panel.
In terms of the biopsy, I think Dr. Gokaslan made some very good points about CT-directed biopsies, which appear to have a low risk of seeding. We do know that seeding will occur related to surgical procedures, and one case that we had seen at our institution was a young girl from South Africa who presented with swallowing difficulties and had a central chest chordoma, and it was because of her swallowing difficulty, surgeon went in through the chest and removed a portion of the tumor to improve her swallowing. She came to our institution, we did radiation and then surgery, and her primary tumor was controlled, and she had diffuse spread of tumor throughout what's called the pleural cavity, the area surrounding the lung, unequivocally related to the surgical procedure. So in patients with mobile spine and sacral tumors where we're planning to operate, after the biopsy, we think there is a value for preoperative radiation. And our data, and it's not opinion, our data show that there's a lower rate of local recurrence in patients who get radiation before the definitive surgical procedure. And when you look at what we refer to as patterns of failure, patients who've had surgery alone, you'll see recurrences outside of the area where the tumor was, but in the areas around it in the operative field where the surgeon was manipulating the tumor. And often these tumors can't be removed with a wide margin. You might be peeling the tumor off of nerves, for example, and those tumor cells can in fact grow in the tumor in the operative site. So I think the points you raised are very legitimate ones that we're trying to address.
I think one of the issues, at least in the skull base with preoperative radiation, is usually the limitation for radiation in the skull base is how close it is to the brain or the brain stem. And one of the main things surgery does is get it away from the brain or the brain stem. And so that allows safer and more effective radiation because of that. There are things that are done at specialized centers to avoid seeding, all the things you've heard the orthopedic and neurosurgeon talk about for the spine. For endonasal surgery, we've developed these little plastic sheaths that go in the nose during surgery, because the only two seeding we've seen have been on the front of the nose, which means it came from bringing instruments in and out. So now we have protective sheaths for that. So there are things that are done at sort of specialized centers to prevent this. And there also are reasons why sometimes radiation can't be used before.
The preoperative radiation seems to help in terms of seeding when possible. And they've been able to show that that idea came originally from bladder cancer many years ago, but the idea of giving some of the radiation beforehand seems to be helpful.
Okay, can we get to the last question?
Just one small comment. I think that's important for people who are not in the United States, that some doctors might hear that and might help people. I don't know if that data will all be included in one final, like Dr. But I just hope that helps some people while magic is being built.
All right, thank you. Thank you.
Thank you for addressing the lung nodules. And this is my question. With multiple bilateral pulmonary nodules, let's say less than 20, 1 to 2 centimeters, and most of them are very tiny, is something bad happening microscopically while we're watching and waiting for them to grow? Would it be better to act sooner rather than later to ensure a quality of life and a long life? And thirdly, have you actually seen patients with these nodules just go along untreated? For how long have you seen that? Thank you.
The first question, the answer is we can't predict the future for any single person. And the best way to do that is to do repeated imaging, I believe, and see if there's a rate of change in those tumors that is concerning. But the answer to your third question is the most important. Almost all of the patients I've had with lung nodules have had very slow growth in those nodules that has not caused them any symptoms during over 3 years of follow-up. So that's all I can say, is that for those patients it didn't, but for a given patient, we would take it as it comes. And that would be follow-up and monitoring of the change. And if there was one lesion that was more concerning, that one would be addressed. If multiple lesions were changing, we would think about systemic therapies that might address all the lesions at the same time.
And sometimes there's value in also making sure they are pulmonary mets.
Yeah.
Because occasionally, patients with tumors are more at risk for developing other tumors. And every year we have patients that find out that we discover, say, a lung cancer or some infectious process or sarcoid or various other things that aren't even related to the original tumor. So that's where a biopsy or removing some of those nodules is sometimes important. But a lot of times they'll want to if they're going to do some experimental or adjuvant therapy, to have something to follow that they're sure is related to that disease is important for
We
size.
don't know if there's something microscopic happening to those, though. We don't know. But we do know that many patients with nodules can go a long period of time without the nodules themselves being a major source of problem for them. It's just a sign, a lot of times, of a tumor that's active somewhere else.
But when you say long period of time, I'm thinking 10 or 20 years. That's a long period of time, not 3.
Oh, no. So that's just while I've been seeing these patients.
Oh, okay.
But I have a couple patients who have had lung nodules for 10 years that have no symptoms from those lung nodules.
Did they grow a little or?
Yeah. they grow
So
tiny.
I've had lung nodules for 9 years. They haven't changed at all. They're there, and we look at them. Who knows what they are? They were found on my initial series of scans. So in keeping with what Dr. Heery is telling you.
Okay.
All right.
Thank you.
So can we give a hand to our panel?